Two, check, two. Two, two. Two. Two.
What I get from my medical committee can't be any worse or any lighter than this, so don't worry about
So,
it.
okay, for the blanket story.
Yeah.
Years ago, we had a gentleman from Stanford
Yeah.
who came and gave the talk. And I sort of warned him because coming in.
So can you believe that Donna Shalala's here?
I see that. That's great.
She is so amazing.
Really?
I mean, the board is amazing. And the session now is punishing. You know, just they have so many good ideas. It's like, how can you possibly operationalize them all? Like,
Right.
And I think they're pleased with the pace and the urgency, but they feel every bit as much urgency as I think a small group of us do.
Good.
Right?
Super.
And
Super.
they're committed to being great, not
I love it.
average. And
Yeah.
I'm like, well, look, Carol Andrew and I had great jobs. We're committed to being great because we're not doing this to be average, because we go back to a much easier lifestyle as a tenured
I'm
faculty member. And so please don't for a moment think we're interested in anything but mediocrity. We're about to be great or we're done.
Yeah. Yeah. I love
So-
it. I love it.
Otherwise, life would be
Was
easier.
this sort of an info session or Q&A for them for you? Or?
No, because we put together 15 pre-reads for them. It's all business. It's right down to discussion and feedback and engagement. Because one of the things that's happened too much in the past is A, they've been underutilized, and B, they're just being presented in one workout. And that's what they want to be workers, right?
Well, good. So I'm glad I'm getting them while they're fresh.
Oh, you are. Yeah. And this is where, that's what we want. We want their attention. We want them thinking about dollars. We want them to think about their networks and how we can leverage their networks and the networks of their networks. And
Fantastic.
and we have really good turnout from people who historically, have not turned out as much. And so, that's really exciting.
I think
There's a lot
that's
of
a signal
talent.
about the energy you're creating that they're interested in
Well, I hope so.
what getting behind what's going on. I mean, that's great.
I hope so. We'll see.
I'm certain that's true.
And given that you're such a sports fan, the guy that just sat down with the kind of olive green jacket,
Yeah.
he's the former general manager for NHLBI.
Oh, really?
Yeah.
Oh, very cool.
And himself a hockey player with a PhD.
Nice. Really
So,
nice. That's an
certain-
interesting guy to speak with. Cool. All right.
Thanks.
Whenever you're ready, Dave. Thank you. So you, yeah.
Good afternoon, everyone. I'm David Van Slyke, and I'm the Dean of the Maxwell School of Citizenship and Public Affairs. And it's my pleasure to welcome you to the 29th Annual Herbert Lourie Memorial Lecture on Health Policy. I would like to acknowledge first, with respect, the Onondaga Nation, the indigenous people upon whose ancestral lands we now gather. As many of you know, the Lourie Lecture is held in honor of Dr. Herbert Lourie, who is a distinguished physician and a member of the national and international medical communities in the field of neurosurgery. Dr. Lourie was a physician who understood medicine as a high calling that demands the utmost skill, character, compassion, and respect. This lecture series is a wonderful opportunity to bring our community together with a distinguished and thoughtful individual who is involved in the issues that animated Dr. Lourie's life. I would first like to thank the Lourie family for their generous support throughout the years, and the Central New York Community Foundation for their generous funding gifts that make this lecture series possible. I would like to thank Len Lopo and the Center for Policy Research and his entire team for all of the care and attention they devote to hosting the annual Lourie Lecture. The Center for Policy Research is home to nationally and internationally recognized scholars who conduct a broad range of interdisciplinary research and other activities related to public policy. They also serve as the home to the Center for Environmental Policy and Administration, the Educational Finance and Accountability Program, and the Lerner Center for Public Health Promotion, which Professor Tom Dennison directs and for which we are grateful. Today's topic is particularly relevant. As we all know, opioid abuse is a serious public health issue. Drug overdoses are one of the leading causes of death in the United States. The Maxwell School is an ideal forum for this discussion. As one of the nation's leading policy schools, our focus is multidisciplinary and interdisciplinary. And like so many of the complex policy problems facing our nation, we recognize that we will only tackle this problem effectively if we have a range of perspectives, researchers, practitioners, and engaged citizens working together to understand the antecedents of this problem, the incredibly negative externalities that result, and through collaboration and learning, develop options for challenging these problems. I would like to thank all of you for joining us for this important talk. It is great to see so many leaders from the public and private sectors here, leaders from business, healthcare, and the nonprofit community. And it is gratifying to see so many alumni who serve our community in important leadership roles. I would now like to introduce to you a person who needs very little introduction, the Director of the Lerner Center for Public Health Promotion, my friend and colleague, Tom Dennison, who will introduce the 2017 lecturer, Dr. Gail D'Onofrio. In addition to his role with the Lerner Center and perhaps the longest business card in the Maxwell School, Tom is a professor of public administration and international affairs and director of Maxwell's Certificate in Health Services Management and Policy. Tom?
Thank you very much, David. Good afternoon. I, too, would like to welcome you to the 29th Annual Herbert Lourie Memorial Lecture on Health Policy. Again, I would also like to thank the Lourie family and friends for their generous support that has made this lecture series possible for nearly 30 years. And I want to thank all of you for joining us for this important talk. It's great to see the broad representation that turned out today, and it's really great to see all the Maxwell supporters, and particularly the Maxwell Advisory Board. The Lourie Lecture is an endowed public address delivered by leading figures in health policy. The lecture is jointly sponsored by the Maxwell School of Citizenship and Public Affairs and the Central New York Community Foundation. It's administered by the Center for Policy Research, and the talk will be memorialized in a policy brief that will be published by the Center for Policy Research and the Maxwell School. This lecture series has a very long history here at the Maxwell School. The inaugural lecture was held in 1989, and as you can see on the back of your programs, we've had the pleasure of welcoming many very distinguished researchers and policy wonks in the field of healthcare since that time. This year's speaker, Dr. Gail D'Onofrio, is one of the nation's leading experts on a topic that has become very important to us here in Syracuse and in Onondaga County and throughout the nation, the opioid epidemic. She's a professor and chair of emergency medicine at Yale University School of Medicine, and she's a recognized leader in addiction medicine. She's internationally known for her work in drug and alcohol research. She's participated in many National Institute of Health panels and review committees, including the National Institute on Drug Abuse, the National Institute on Alcohol Abuse and Alcoholism, and the National Heart, Lung, and Blood Institute. Her research and publications have appeared in very high-impact journals, including the New England Journal of Medicine, the Journal of the American Medical Association, Annals of Emergency Medicine, and more. So please join me in welcoming Dr. Gail D'Onofrio.
Thank you. Can you hear me? Am I turned on in the back? Okay, great. So thank you, and I'm honored to be here, and I hope I live up to all of your expectations. And the best I can do, hopefully, is tell you a little bit about addiction, at least from my framework, and some of the things that I'm doing with a large amount of colleagues at Yale and also within the state of Connecticut. So I thought I'd start just by the faces of addiction. And this is a little biased in that you'll see that they are all white. And the reason for that here is the way this came out is that David Armstrong, who's part of STAT, which is owned by the Boston Globe, is an organization and journalist who actually take things that are really relevant at the time and try to get them out. So last year in 2016, he looked at 52 weeks and 52 faces. And how he got them were that people wrote in obituaries and really life stories of the people that they lost. So I think that's relatively biased in that there are more white people that would probably do something like this and be online. Although we do know it is a much more white disease, but these are the people. I went through all of them, and as I was saying earlier, as my research assistant said, I'm not going to look at anymore because it's just too stressful to read the stories. But anyway, these are the faces of addiction, and they are all people. Oh, we're going the wrong way. They're all people that you could identify with. So 27-year-old fitness buff from Norwich, Connecticut, 24-year-old engaged in Alabama, 27-year-old, one of 9 children in Tolan, Connecticut. James, 32-year-old, father of 2, Cleveland, Ohio. Johnny Chris, 52-year-old grandmother, Mansfield, Ohio. Jesse, 24-year-old, one of 3 brothers who died of an overdose in Rockland, Massachusetts. Emily, 22-year-old mother, Camp Hill, Pennsylvania. So you could go on, and they tell their stories, and you can always look this up on Stat at any time that you want. But it kind of show you that these are people in the community, people that you could know, and really lives that are shortened unnecessarily. Some of the themes that I'll go over and I think are really important is that words matter. And if I can do nothing else, if you remember anything else from today, is to remember that, and that we use the right words. So we are trying very hard to see that things could be very stigmatizing, and as it's stigmatizing, people don't seek treatment, they're ashamed. And really, it is a barrier to care and to how we approach this. So we see these things everywhere. Even Yale puts this out. A pediatrician finds new ways of approaching treating babies at addicted mothers or addicted babies. No such thing, I'll tell you, as we go through. An addict, now clean, discusses needle exchanges and hope after heroin. We're going to talk about not saying this, these words. Families' hopes others can learn from heroin addicts' death. Instead of talking about it in terms of a person, it is a person with an addiction, it's a person with diabetes, it's a person with hypertension. We don't say that diabetic over there or that whatever. They're not defined by their illness, they are individuals. Another man journeys from an addict to a graduate. Addicts gain attention as heroin open use rises. So we're trying very, very hard, and I'll go through some of the things that we are doing to get journalists and to people to talk about this as a disease. Even though many patients will speak of it, we say, you may call yourself an addict, but I'm not going to refer to you like that. You have an opiate use disorder, you have an addiction, I'm going to help you treat that, and that's how we're going to do it. The other thing is that accurate words matter, and often what you will read in the newspaper, just like everything else, or on the news, fake news, things are not accurate, and so we have to be really careful, and we work with a lot of journalists to make sure that what they're putting out there is true. So just little things that, like a typical overdose, this is New York Times, pills that a doctor prescribes legally, but that someone other than attended ingested. Well, that's not the typical overdose. You'll hear the typical overdose is heroin and fentanyl right now, although they may have used these medications in the past. Or another suggestion is Narcan is ineffective in fentanyl. It's not ineffective, it's an antagonist, it works fine, you just need more of it than we needed in the past. So these things get out there, and then people say, oh, I don't know what to do, this is not effective. So we're working really, really hard, and I have to say the New York Times put out a great article on Sunday, and it was pretty much everything we've said in our Connecticut core response to opiates. So we're thinking that people are listening to us at some point. So we all know this. We have a horrible epidemic of opiate use disorder. This is just recently from the National Survey on Drug Use and Health. If you know that, it comes out every September. It always comes out from the year before. This just came out in this September, but it's 2016 data. So we know that over 20 million Americans age 12 or over have a substance use disorder. 2 million of those are opiate use disorder, and 1.8 involve pain relievers, and only about 0.6 involve heroin. And many more report the medical use of pain medicine for non-medical use. If you look at this, which they came out with, which is a little complicated, but just so you get an idea, there are 11.8 million people that are using or misusing opiates, and this kind of yellow circle here are all the pain reliever misuses, and this little circle here are people who use heroin. And in here, only the red part are the group that are just using heroin, and these are people that are using prescription in this. So although this is a small group of this, these are the patients that are really dying. And we know from all of the work that we've been doing how this national rate of increase in ED visits and in rates of inpatient stays are going up and up every year. This is some data that the Agency for Healthcare Research and Quality, AHRQ, puts out. It's around their utilization project, their healthcare utilization project. 30 states contributed to this, so it's 30 states only. But you can see the cumulative growth here of ED visits per 100,000 up to 2014, which is the last data we have, and the number of inpatient visits. If you look here in New York, all right? Your numbers are even higher. You're in the group of, quote, better if you want, or worse. And so you're at 360 per 100,000 for inpatient stays, and 185, almost 186 for ED visits per 100,000. And this was 2014. I bet it's much, much higher when the new data comes out. So from our use of and CDC results, this is a map of just showing the overdoses in the entire United States. All you need to know is that it's pretty blue, so it was lower, and the only red pockets, which are the worst, 26 to 28 per 100,000 adjusted rates, death rates, are really here in the Appalachian Valley and here in New Mexico. And now if you contrast this to 2015, you can see there's a lot more red, right? And New England is really up there and not doing well. The Appalachian Valley is getting even worse, and obviously over here in the West is getting worse as well. So really people are literally dying every day. There are young people in general who are dying, which makes it worse. My colleagues who work in tobacco always tell me there's many more people dying of tobacco, but it takes a really long time to die, and you have a lot of time to intervene. This, unfortunately, we don't have a lot of time to intervene, and many times it may be first use. So again, this from the CDC showing you that the number of overdose deaths are really rising over the years, and these are often now from more synthetic heroin and synthetics that are really rising astronomically more. Many heroin users do start with prescription drug use at the beginning and do move on. And why is this happening, and why is so much fentanyl reaching the market, and what's going on here is that, you know, fentanyl is purely synthetic. It's apparently very, very easy to manufacture. It's brought in a lot from China and from Central America and South America as well, but it's really scary and it's cheap. So you don't have to have a plant and develop the plant into whatever you want. It can be made, and you can sell it for almost the same price as that you could sell heroin for, but since it's cheaper, you make 10 times, 20 times more money by doing it. And so we're seeing so much of it and so rapidly, and it is so powerful that it's killing people even when they try it. And often people don't even know that they're using it. They may think they're using cocaine, they may think that they're using heroin, and they know exactly how much to use, and now they're using something that's so much greater than that. And here you can see a difference between a real Percocet oxycodone pill and a counterfeit. So other than the medical profession who look at these, they're not going to know the difference. They're going to look and see what, you know, numbers are on it, what does it look like? And we've had in Connecticut multiple deaths with people buying pills over the black market or from anyone and thinking that it was Percocet or oxycodone, and instead it was fentanyl, and they die. One pill, they're dead. You can see there in the bottom how potent these are. If morphine is the equivalent of 1, heroin is 2 times that, but fentanyl is 100 times more potent than that. In Connecticut ourselves, a year and a half ago, we had 18 overdoses in a very short period of time, 3 of which died. All of them thought they were taking cocaine. They were all taking fentanyl. And so we used a lot of Narcan in the field. We ran out of it because they needed multiple doses, and people were dying. We couldn't figure it out until finally, and we can't even test for fentanyl in most hospitals, so you're just assuming that that's what it was by the nature of the disease, and 3 of those people died. So the deaths are climbing. It's estimated that, you know, these are always behind. That's a problem with our surveillance. We're just getting out 16 to 15 data now. We think that 16 data will be at least 65,000 deaths, and that will be estimated to be more like 100,000 in a few years. So what are these special impacts on certain populations? One of the things here is adolescents, and this is where it's really important that adolescents are misusing more than they did before. And the overdose rates have gone up from 1.6 to 3.7, so over twice as much per 100,000. So this really talks to us that you really need to start young with prevention, really young. And I'm not sure what that is, but there's some colleagues here who are going to help me figure out what are good things to do, and we need to work on this. Women are particularly affected as well, and this is one where women were less likely to be affected before, but we're catching up, and this isn't one of the areas that I want to have gender equity in, but we seem to be. We become dependent more quickly, we use it differently, smaller amounts of time, and smaller amounts tend to help us get dependent. We're more sensitive to cravings, and our death rates are rapidly rising. The other is older adults, and older adults, the prevalence is really going up as well. And people are misusing, and that in combination with, as we get older and having chronic diseases and using other medications and co-prescribing, makes it more difficult. Also, as we know that in cancer therapy, people are doing well with cancer, but they often may be put on opioids to begin with, and now the people in my hospital who do hospice palliative care are now coming to us and saying, help me out, this person's living a lot longer than we thought, they're not in any pain anymore, and now they're all dependent on this medicine that they've been on. So how can you help us? So in spite of all that we said and how prevalent this is, only 1 in 5 people get treatment, and that is really abhorrent. And we're all here working for the same thing, and that is to get people in treatment. And I'm going to tell you a little bit and step back, because I think this is interesting on really where this last 100+ years came from, how we got in this spot that we are, and some bright spots of how we might get out of it as we go along. And many of you may have read about this recently, because I have put this together for the last couple of months, and then my husband just emailed me the other day and says, you should read this thing in the Washington Post. And I said, oh my goodness, that's in my talk. So it's out there a lot. But you know, we know about opium since Hippocrates in 400 BC. A German pharmacist extracted morphine in 1803 from opium, and he called it Morpheus for the Greek god of dreams. And around that time, we began to have our first epidemic in the 1800s. It was considered one of the most useful drugs in the world and in the physician's arsenal. What happened was that although it was out there and people were starting to use it, it really tasted badly and apparently had a lot of GI symptoms. So it wasn't used as much as it could be, even for acute pain, until we developed the hypodermic needle. And that was developed in 1853, and that became very successful in the Crimean War and in the US Civil Wars. It helped a lot of acute injuries on the battlefield, but what it ended up was getting 400+ soldiers with soldier's disease, which was really an addiction to opiate use disorder. So then as we moved on in the 1800s, addiction became very widespread. Bayer makes aspirin, as you know, just as around the same time as aspirin. They found that there was a better drug that could help with pain than aspirin, and it just happened to be called heroin here, and that was a big improvement. And that was used for everything. And so what you have to think about when we move forward into our current epidemic is how this worked. This was pharmaceutically driven. Physicians and pharmacists contributed to that, and we came where we are today, and this is exactly what happened really back then. Without any knowledge of anything, it became touted as the best thing since sliced bread. And it was very unregulated. It was given for everything. Housewives, and as they talk about these gentle women, really had an addiction. They were given it for everything, from menstrual cramps to anxiety to whatever, headaches. This was the right thing, so it became very unregulated. And so then what happened a little bit before we go into there is that people started to notice, and actually Teddy Roosevelt was really instrumental in this and put an opiate commission together with a physician from Ohio and started to talk about it throughout everywhere. And we finally got the Harrison Narcotic Act, and morphine became a controlled substance so that it was more regulated. Around that time, we also had the FDA come out and say, you can't just put this opium stuff and heroin in everything. It was in codeine, I mean, it was in cough medicine, it was in any tincture of anything that you would give out. You can't do that anymore. You have to tell us when you're putting that into medications, and we're going to control where you can use use it, and we're going to control how you distribute it. And so that really did help and stop this. And fortunately, back then, we didn't have a lot of illicit drug pushers. And so they were able to get by this period of time with better knowledge, better physician knowledge, better regulation. They got themselves out of it. As we move along, we developed methadone, and we introduced methadone treatment centers. And this was sort of like our next real issue. It wasn't as big as that first time when it was all over rural and urban areas, all over the United States, and how it is today. This next one was really a combination of a lot of GIs coming back from Vietnam and really having widespread domestic proliferation on the black market of heroin during that period of time. And heroin injection became the leading cause of death in the city of New York. And so these new methadone clinics popped up. We were able to treat it, and we did a fairly good job about it. But also in that period of time, in 1971, was the war on drugs. And we will figure out that that didn't work. So we put a lot of people in jail, and we weren't really able to treat the people or prevent the people. So now we move on further, and this is what happened now. So now all this stuff led up to our current state that we're in, and hopefully we can learn a little bit from our past experience and maybe help ourselves out of this. We recognized pain was very untreated. When I was a resident, it was like we didn't give enough pain medicine out. You have to say to a patient, you know, I have more pain med than you have pain. That was what we were taught to say. We were always thought that we didn't give as much out as we could. In '96, pain became the 5th vital sign. So when you come in the ED, not only do we do your temperature, heart rate, and your blood pressure, et cetera, we asked you about your pain. You got this little thing here. If you were over 4, we were required to give you pain medicine. And you know, it's very subjective. And just recently, it's just months ago that this kind of went away. And what happened again was the pharmaceutical companies. This time it was OxyContin from Purdue Pharma. So OxyContin was bought by these brothers from New York around the 1950s, and one was a psychiatrist and one was an advertising person who owned a company. And they then decided, well, we got this new drug on the market, it works really well. There was really very little data to support that it was not addictive. They just kind of made it up. But they were great at advertising, so they went out, and they are really the pioneers of people who did academic detailing, which to this day, we have pharmaceutical reps who try to come to doctors' offices, and now if you watch, it's my husband said, if you watch a football game or any TV show or a golf game or whatever, you can't get away without pharmaceuticals. It's the entire thing, right? Viagra mostly, but it's other things. It's, you know, arthritis drugs. It's everything you can imagine, and it's all out there. And this is what they did, and they did a great job with it because they told every doctor that this is going to take away everything, all of your patients' problems. It's never going to be addictive. It's fine. In 2001, the Joint Commission that accredits hospitals and health systems came up and said, you need to have these pain management standards. You need to do this. You need to, if you're over 4, you need to give these people pain med. And you can start with ibuprofen and you can start with Tylenol, but if that doesn't work, you got to step it up. So, and then, to make it even worse, CMS linked our reimbursement and our patient satisfaction with this. And then our patients, and I would come, people, this is not long ago, last year, people would come to me and just tell me, your patient sats are bad. Patient sats are done in EDs by people that go home. So by definition, they're the less sick people, right? And all I need is 5 people to tell me, I didn't like you because you didn't give me my pain med, and that would tank my scores. Being in an academic center, we don't really pay people by this, but there are many emergency departments throughout the country where the physician is paid by their patient sats. Very big portion of their salaries come from this. So these combinations were a perfect storm. So now we have us all contributing to it, and here we are. So then we started giving out tons of pain pills, and this ends here, and it went up and then it's going down now. So we have a pain pill for almost over 200 million people. So 2 out of 3 people in this country get a pain pill prescription every single day. So every single year. So now that led up to here, and also you can see here the standard doses of opioids per million. Americans by far consume all the opiates in the world, and here we are. All right. We're doing a little better. but so now we're maybe here, but we're still bad. So that led us up to all these things that we're talking about now, and that's why the prescription opioids went up, and then we found out we could use fentanyl and heroin, which was better because prescription opiates are very expensive. On the black market, each one of these pills is somewhere between $10 and $25, and a person's gonna need 6, 8, 10 of those a day. You can see they can't do it. I can go out and buy a bunch of heroin for less than $10, and now I can buy fentanyl for less, right? So now I've got something very inexpensive. It's a bad business model to kind of like kill off your clients. So you want to hope that they're not passing off fentanyl all the time, that people know what they're getting. So let me step back a minute and talk to you also about the intersection between chronic pain, opiate use disorder, and experimental use. Both of these can lead to opiate use disorder, but there's a real big difference between them, and we have to be careful. There are a lot of people who have chronic pain. It affects over 100 million people, or 1 in 3 of us. 25 million Americans suffer from daily pain, and 40 million from very severe chronic pain, and it costs us a lot of money and a lot of decrease in productivity and salary. So we sort of have to figure this out and figure alternative ways to deal with pain than what we thought we could do, which is just write this script. And then, of course, there are people who use experimentally, and some of those will be fine and will live through it, and then some of those will go on. And what actually is this opiate use disorder? So, and what is actually addiction? So the DSM, the Diagnostic Statistical Manual for Opiate Use Disorder, has a whole list of things. There are 11 things, and depending on how many things you're positive for, then you have a diagnosis of an mild, moderate, or severe opiate use disorder. But really what it is this first part. It's taking it in really large amounts. It's taking more of it. It's doing things that you cannot stop. No matter what you try to do, you won't stop it. You will do these things no matter what happens to you. You could lose your family. You could lose your job. You can lose everyone that was significant to you. No matter what it is, it really doesn't matter. I'm still going to use it more. And I'm going to stop doing other things that I used to do because I have to spend all of my time thinking about when I'm going to get my next drug. And I don't really care how much I do it. That's what it is. That's what is addiction. What it's not is tolerance and more to get this desired effect, because that could happen with people who need chronic pain meds. If you have sickle cell disease, for example, you're going to be on chronic opioids. There's nothing we can do about that. And you're going to need more and more as time goes on, and you're going to have withdrawal when you stop it. And other kind of crazy, horrible cancers, we're going to need to do this. That doesn't mean that you have an addiction, because you're going to go to your doctor, you're going to do the best that you can, you're going to have a certain amount of medication given to you. You might pass up into here, but it doesn't mean that you are going to pass up in here. So it's very different with someone who's on chronic opiate uses than if you have an addiction. And addiction is really, sorry, I don't want to make you dizzy. Addiction is not a moral failing, okay? So if there's anything else I can tell you, it is a chronic relapsing disease. It has nothing to do with your ability to change that. And Robert DuPont, who is I think he was the first director of NIDA, once told a story that I found very compelling, and that is, you are driving a car, and this car is in a suburban area, and you see that this kid is running across the road, and you need to stop, and you're going at a fairly fast clip, and with all your might you try to stop. You say, I gotta stop. I'm going to seriously hurt or not kill that child. I need to stop. But the brakes didn't work. Right? And that kind of gives you an idea that there's nothing I can will myself into here to change. That it is similar to diabetes, cancer, and heart disease. It has a lot of combination of behavioral and environment components. There are some genetic components to it, but there is nothing I can do to will myself out of this disease. And there are profound neurobiological changes that occur when I transition from use to opiate use disorder. And that's the basis. I'll tell you a little bit about pharmacology and some of the binds we get into, but we need to stabilize these neurons, the neuronal circuits that have been adapted and kind of hijacked. The brain has all these different areas in it. Ones that we talk about a lot are this reward system. There's a lot of dopamine. This is a neurotransmitter that goes up when something's important to us. It's why we eat, and we will always eat to survive because we like food, and that's the way it is. It's why we have sex and we generate our species, is all from this. It's very similar, except that this reaction when people start to use heroin, and why it happens in some people and not others, and why people can control it at some point and not, we don't know enough about it, but this system is hijacked. It doesn't matter what you do, this system will just go, and this person will do no matter what they have to get that drug. And it also affects their prefrontal cortex, which is our judgment. So now we have no judgment. If you tell me I'm going to go out and die if I use that, doesn't really matter. I'm going to go out and die. I just have to do it. And so this is what happens when people have an addiction. They're high all day long. They're often getting an injection. They may get some relief from that, and then they go down and have less relief from it. Every single time they get less of this and more of this dysmorphia. So it's not what people may think, that these people are going out there, they're shooting all this stuff, they're just always in this perpetual high. They aren't. They're always trying to get out of feeling badly, and that's really hard to do. They have these horrible withdrawal symptoms. You can't die from them, but you wish you could die from them. Irritability, restlessness, nausea, abdominal pains, achiness, like the worst flu you could imagine 10 times, and you just can't get away from it. When you are on, whoops, I think I had another one. When you are on an agonist, an opiate agonist therapy, which means what we'll talk about, methadone and buprenorphine, you stabilize those functions, and you feel the same the whole day long. You're not high, you're not low, you are quite able to function in that capacity. And so what do we know from evidence-based therapy is that we know that this works. Medication is very effective with opiate use disorder. We call it MAT. A lot of people don't like to say that, because if we have diabetes, we don't call insulin our MAT, even though there are a lot of behavioral things we need to do with that. We need to lose weight, we need to work on our nutrition, we need to have good foot care, we have to have good eye care. There are a lot of things that we need to do, but we don't call insulin MAT for diabetes, all right? It is the treatment of diabetes. And similarly, a lot of people will want to say it's medication for addiction treatment. It's not necessarily assisted. We know this works. I have 10 slides that I could go through with you that show you all the data that's out there. I chose one which was from Baltimore that had a huge problem, and what you see over the years is that this was buprenorphine use, this was methadone use, and as these went up over the years, the death rates have come down. This happened in France and other places. It happened in Finland, and it happened here. Multiple things that told us that this worked. Many other articles have come out recently in the British Medical Journal, a major analysis of multiple studies came out to show that MAT will prevent overdoses versus people who are not put on MAT. So these are the advantages of it. It not only reduces illicit drug use, but it causes less transmission of hepatitis, HIV, and less complications of IV drug use. It definitely reduces, as I said, overdose and death, reduces risky behaviors such as having sexual activity when one may not want to, reduces lots of legal consequences. People are not going out and stealing things in order to get money, and it really has more time available to sustain relationships, find meaningful employment, and deal with all of the other medical problems that people have. So we know that it works. And every dollar spent on this is great. And additional treatment yields a return of $4 to $7 in reduced drug-related activities such as crime, criminal justice costs, and theft. And the total savings to the healthcare system is high. This came out in 2012. I'm sure things will come out more currently that will even be more. It is endorsed by all these organizations. So we have the evidence behind it. We know that it works. We know if you don't use it, people are going to die more. And we know that's been endorsed by almost every agency you can think of, the World Health Organization, the NIH, the National Governors Association, the Surgeon General, the Office of National Drug Control Policy, all these things the president has put together, these committees and stuff, and SAMHSA. So everybody has endorsed it. However, whoops, didn't flip up. However, I missed something there. However, even with that, and even with this address that Dr. Volkrol, who is the NIH director of NIDA, and Francis Collins, who is the director of NIH, came out and said in the New England Journal just this past June, these medications are the current standards of care for reducing illicit opiate use, relapse risk, and overdoses. However, there is limited access that many things that can create barriers to treatment. So in spite of all this, in spite of everyone coming out, only a third of drug treatment centers use MAT, right? So when kids are sent out there and go to these places, whether they're in Florida, even if they're in Betty Ford, and Betty Ford is coming over more to using MAT, but many times they do not. Even when they go to these places, they're sent away for a month, they come out and they die. Right? And they die because you've made them less tolerant for that month that they're in this cocoon. They come out and they die, and we know that. Whether it's from incarceration or whether it's treatment facilities, they die. Right? And so we need to be really, really careful. Those circuits I told you about don't change. We don't have any idea when they will change. We have people who are in recovery for over decades, and then things can happen to them. So we don't understand it, but we do know we need to have them on medication for a pretty long period of time, and then maybe we can start to withdraw it at some particular time when everything else in their life is perfect. So again, the big meta-analysis showing us that it's okay if you do counseling, not saying counseling is wrong, but you don't need counseling to have medication to work. It is the medication that needs to work. And counseling, of course, can be additive. We do need life coaching. We do need people to get back in be viable working and viable pieces of society, members of society. And of course, there are people who have real mental illness, and those people need to be treated. But we must get these patients into MAT. So what is it not? It is not detoxification. It is not an abstinence-oriented treatment. It is not mutual support groups. And it is not naloxone, which is just the antidote. None of these things are treatment. None of them. It doesn't mean you couldn't have some of these things. Recently just came out again in a big organization, I don't know if it was the New York Times or Washington Post, somewhere just last week, which really finally came out to say, why are we having these AA, NA, telling patients and individuals that you don't want to take medicines, you need to be off of everything. We're killing people like that. We can't go on like that. We need to do what we need to do, and we know that works. This is a study that was just recently published in JAMA and this year, and it looked at all this medication-assisted treatment from people who are in the Pennsylvania Medicaid system. And what it did here was it showed you people who had overdosed on heroin before and after, and people had overdosed on prescription medications before and after. And then it just showed you what happened afterwards. And very few, a little bit more, but not enough of these people were ever put on treatment after they overdosed in whatever category they were in. So we need to fund treatment, and we need to promote behavioral health parity so that people have the money for this treatment. The Urban Institute recently published this, which looked at the rapid growth in Medicaid spending on medications to treat opiate use disorder and overdose. This shows you all the medications. Really, this is the antidote, but these are medications, buprenorphine, naltrexone, and it showed you the money that was being used for all these drugs over the years, and this is good. It's going up. And if you look at it in terms of the states who have the ACA expansions, if you were in an expanded state, you know, the money was going up and people were getting access to it for both buprenorphine, naltrexone, and even the antidote. If you're not, and you're here in a non-expansion or a late expansion state, money is not being allocated for this. So we need to make sure it's that, and contrary to some congressmen who think that Medicaid expansion accelerated this process because then they got to see doctors and they got put on more opiates, that is not true, all right? So we need to make sure that we have access to medicine. So some of the solutions that we're working on, and I particularly am, is we know that arrests don't work. We've already been there. Our jails are full of people, and this war on drugs only just led to more and more people being incarcerated. 85% of the US prison population either has an addiction or their lives were affected by substance use. That came out from CASA last year. So what are some solutions or things that I can as an emergency physician do? And that's I can work on treatment, and particularly on increasing access to treatment. So why the emergency department? We are the front door of the hospital, and we are where the patients are. So once a famous bank robber was asked, you know, why do you rob banks? And he goes, I rob banks because that's where the money is, right? So we are here, and our patients are here, and they're here every day, so why not use the emergency department as that face? Either people come in asking for treatment, we screen them or see them for other things like abscesses from injection use, or they present with an overdose. They're there already, and we can help them. So we had this great idea. What if we could initiate treatment while they were in the ED, since many of these are young patients, they don't have other chronic diseases, and they don't really see doctors for other things. Maybe we could initiate this treatment, and maybe we could make this direct linkage. So we shifted this paradigm and said we could treat overdoses like any other emergency or anybody who came in with an addiction, and we could do that with buprenorphine. And the reason we can do it with buprenorphine is that since 2002, we are allowed to actually dispense and administer buprenorphine. Buprenorphine is a partial agonist, which means just to you it has a ceiling effect. And after that effect, it doesn't work anymore. It is very, very affinitive to those receptors in the brain, whereas methadone is a pure agonist. You can give more and more and more and more. It's much more lethal, actually, as in overdoses. And then, of course, naloxone is just an antagonist. Not to be confused with naltrexone, which you might hear a lot about treatment. Naltrexone is not naloxone. They're both N's, and people, even doctors, say, why did they have to name them the both? They seem too similar. So buprenorphine was something that was very potent. It was it loves to sit on those receptor sites. It's often combined with naloxone so that you can't use it illicitly IV, so you can't burn it up, and has all these different properties associated with it. And we got these X waivers that said certain doctors could give out this if we took 8 hours of class, either 4 hours on a computer and 4 hours in person, we could get an X waiver. Right there, that's complicated because I can give out 1 million OxyContin pills and I don't need to do anything else, but I need to do 8 hours of training for this. But there was one cool thing about it for emergency physicians is that there was a rule put in there that said we could treat people by administering it right as one dose and bridge somebody to go to treatment. So anybody that even doesn't have an X waiver could give one dose. And we'll let you bring that person back for 3 days, 2 other days, so a total of 3, and give another pill. We want you to hand them out 3 pills. Won't let you write a script for 3 pills if you don't have an X waiver, but we'll let you bring them back to the ED for 3 days until you can get into treatment. So this is very helpful, but it's only helpful if I have someone to send them after that period of time, because I'm not allowed to do it without an X waiver after 3 days. So we did this study, and to make this fairly simple, is that we were just trying to see what we could help emergency departments with opiate use disorder, how could we treat them? One aspect was just referring them, and that referral was more than your typical referral because we didn't want to do that. It's based on their insurance and whether they wanted it, to go into treatment if they wanted inpatient, outpatient, whatever. We gave them a phone and said, okay, here's the place for you, give them a call. The second one, we did this little psychosocial intervention, telling them about how they should be motivated and telling them about using some motivational enhancement skills into wanting to go to treatment. And then we did a facilitated referral. We actually called that place. We said, you know, there's a spot there, they're waiting for you. If you have insurance and are going to an inpatient facility, we can actually even do get clearance through insurance companies. We can do everything to get you there. And then the third part was that we decided we would give them a dose of buprenorphine in the ED or a take-home if they weren't quite ready to get that dose. And we would set them up with primary care, follow-up for 10 weeks. And we knew we would do better, but we didn't know we would do this better. So at the end of 30 days, almost 80% were in a formal treatment program. These were higher than I anticipated, but again, those weren't your typical get out of here. All right, we did things with them. But this was really surprising to us that we did so well and people were in formal treatment. People have said, well, what do you care about it being longer? We actually showed further than this that up to the time we were doing it in primary care for 10 months, we still had a lot of people in treatment. We did not have such luck afterwards because we had to refer them to other places. But our point in emergency medicine is not how well buprenorphine works. I don't even know if we send people now, if they get buprenorphine or they get methadone, they're sent to a opiate treatment program or a provider that gives out buprenorphine. I'm not doing that in emergency medicine. I'm just trying to get them there. Once we get them there, then we need to do a lot of research into how do we keep them in treatment. You know, what are the kind of predictors that will keep people there and not? We haven't done a great job of that all over. We also found they reduced their 7-day illicit drug use. So that was another cool thing. And we also found that the amount of inpatient treatment, obviously in our buprenorphine group, who was mostly treated in primary care, had very little inpatient treatment compared to the others, and of course that's very cost effective. And this, I'm not an economist, so for the economists in here, I have to have you talk with Dr. Bush. But we did, Dr. Bush from the School of Public Health really did a whole analysis looking at the costs for care in the medical system and really found out that for every willingness to pay of every dollar, whether it was for treatment engagement or whether it was 1 day free of opiates, for every dollar buprenorphine was better. So it really was cost effective. And when we think about it, for opiate use disorder, we often say we need more chairs, we don't need beds. There's you really don't need inpatient stays for this, you need the medication and then hopefully some other wraparound services, whatever those may look like. Even in our primary care, we talked about, you know, how to staying out of places or with people that would get you into trouble and different things that would happen to you. If you were to use again, you know, how to stay in safe environments, what to do in certain situations. So we always did that. So we found that it did work. And so we concluded that with buprenorphine treatment and follow-up in our primary care, we engaged people in treatment, we decreased their illicit overuse, we reduced inpatient addiction services, and it was very cost effective. So why did this cause such a big splurge? This Milbank Quarterly came out from Joshua Sharpstein, who's from Baltimore, and he said, okay, these Yale people did this and it didn't cause such a big thing, and really given the multitude of this, it should cause an earthquake. Well, I'm glad to know that there's a little rumbling over here. Dr. Sullivan's doing it here at Syracuse. They are doing it around the country, and we're hoping to get more people involved in that. So how do we apply this to the real world? Here's a person who comes in as an overdose, and these are real patients. She's pulled out of from a private vehicle, and she's unresponsive. Her oxygen is very low. She's given naloxone, and she wakes up and she said she had just switched over from prescription to IV heroin. And why is this different than any other emergencies? We resuscitate people all the time, and we do it in a very, very specific way. We have the highest level of triage for people who are about to die. Huge priorities. We do all this stuff in very predictable detail. for other things. And examples of that are stroke and for myocardial infarctions, MIs. For MIs and stroke, we come in, we have all these times to needles and door to needles. So I've got to get people that clot busting medicine, TPA for a stroke. I got to get them up to the cath lab. I'm on the mark and I have to do it 5 minutes for an EKG, 20 minutes to come upstairs, 90 minutes to get that vessel opened. I have all kinds of things that we do. I don't give people a pamphlet and say, you're having a big heart attack, all right? However, it's Friday, so I'm gonna give you this pamphlet and you can go out and find someone to open up that coronary artery for you, but you know, with your insurance, I don't think you're gonna find somebody for a couple of weeks, but here's a whole list of these places. See you later. All right, or I shock somebody out of a arrhythmia that was lethal, and I go, okay, here's the list of cardiologists that might be able to put a pacemaker in you and a defibrillator. But I do exactly that for these people who are dead when I see them. So what we have done is we save their lives. They come in, they're dead, I revive them. All right, and I observe them, and often we say, oh my goodness, thank God it was heroin. We don't have to observe them for very long. It's a short-acting drug, get them out of here in a couple hours, all right? So now what we're trying to do is let's not do that. Let's observe them, and let's start treatment with them. Let's start to engage them in this conversation. And even if they didn't come in for an overdose, but we know they're gonna die from a variety of other things, let's try to engage them. Whoops, I don't know what happened. Oh, there we go. Now, let's give them a facilitated referral. Let's start that. Let's give them a referral. And then, not only that, let's do some harm reduction and give them some naloxone to take home so that we can teach their family members, we can tell them, even if they don't use it, they'll have friends they're probably using, and they'll have some available to them. So why can't we do this? And then we can really save their lives, all right? So we are, to tell you, we are doing this where in Connecticut, they're doing it here in Syracuse, we're doing it in a lot of places, and we'll see how that happens. And one of the things you asked, I wanted to just go over for a few minutes, is that this is our Connecticut opiate response, or CORE, that our state got together, and these are my colleagues here, and the 4 of us from Yale. We wrote this document, but we didn't do it on our own. We had a zillions of partners. We had all different kinds of people from all these different agencies who came together to help us. We gave our time. One of the first things we went, they said, what are they paying you? I said, they're not paying any of us. We're doing this ourselves. We're gonna come up with a strategic plan. It's much harder to implement that than it is to come up with a plan, but we said we can look at all that, we have the resources to look at all this data, and we'll try to come up with something, because in Connecticut, we're having astronomical, we're one of those really, really high states, and we had 1,000, are having 1,000 deaths probably this year, it looks like, and more, I'm sure, to follow. So we did the governor's plan, and this was basically it. We decided that the first thing we wanted to focus on was reducing deaths, and it doesn't minimize, as people said about prevention. Prevention is important. We were just putting the tourniquet on, and then we really have to figure out how to stop this. But we were just going to start with this because we had limited, basically the governor said, do what you want, but you don't really have any more money. So we were trying to figure out how we could come together from the state. And these are the things that we did: increase access to MAT, reduce overdose, safe prescribing, increase access to naloxone, data sharing, and reducing stigma. So we already talked at length about increasing MIT. We really tried to figure out how to tell people that they were at risk for overdose. Obviously, if you had a non-fatal overdose, if you were leaving a residential treatment center, if you were leaving incarceration, and we have lots of things that are going on in working with our prison population. We are trying to get people to prescribe lower amounts of morphine equivalents for cancer, or no matter what, even if you're prescribing it for what might be a good thing to do. We need to tell people to be careful when they use it with benzodiazepines, although people do use benzodiazepines who have opiate use disorder, and we're not going to stop that, but we have to make sure people understand that it could be a problem if you inject it, if you use fentanyl, and if you have sleep apnea. This is another big deal where you're at risk of overdosing. And we're trying to reduce that by getting them into treatment, by giving naloxone to people who need high prescribing amounts of opiates. So if you are on a cancer medication or whatever, that we make sure we tell you and your family about that. we're trying to minimize our logistical barriers and our financial barriers and kind of decrease as much, at least make an awareness to doctors when they're prescribing medications together that these could be at risk for overdose. And we're doing a lot around safe prescribing. So all the states except Missouri have these medication monitoring system, prescription monitoring programs. In the state of Connecticut, similar to here, I'm sure if you write a script for more than 72 hours, you have to look in this PNP before you can do it, and it has a list of all the prescribers and all the people who are giving medicines. This is not a panacea. People who are buying off the street are obviously not here, but it does help you. It helps you too for people who are taking it as prescribed, but they're having problems when you go back and see how many people, different doctors they're going to who are prescribing these. Missouri is the last hold that I had that in another color. I forget what, sort of like in an orange. I thought it was going to go because they thought it passed a couple of different levels of legislation, but it was still held up. So people just go in here to buy their medications or go to different doctors. We did find out that if we did this, that this was associated with less deaths, and so this has been reported. An estimated 600 fewer overdose nationwide in 2016 with the implementation of this. So it does work. And we also had that the CDC came out with guidelines for doctors to be using them. To be using opioids, and they told us what we should do. And we really learned from data that 3 days or less is sufficient for most things. Sometimes we don't even need them, but we rarely need to go beyond 7 days. And this came with data associated with it. So that was published in the Morbidity and Mortality Weekly Reports just recently. What this shows is that for every increase over 3 days use, that the probability that this person will need long-term use is much higher, whether it was a year or 3 years. So once I get beyond 3 days, that probability goes much higher that they will be using long-term opiates. We also learned, here is in the New England Journal article that came out, this is a really interesting study. These researchers actually looked at an emergency department, and they looked at all the different, and these were all Medicare beneficiaries, and they looked in this ED from several from 2008 to 2011, and they looked at the prescribing practices of all the doctors in the emergency department, and they labeled them as either being low prescribers or high prescribers, depending on how much they gave on naive patients, so people who weren't taking opiates before, they didn't have cancer, they didn't have any reason to do it, and they actually adjusted for their severity of their illnesses and all that. So they looked at this and they said, oh, like Dr. 1 just gives a couple of days, Dr. 4 gives lots of pills out for the same diagnosis. So then what they did was then look later on, so they looked a year later and saw how many people within 6 months to a year were on at least 6 months of long-term therapy once they were placed on it by this first doctor. And again, they were opiate naive patients, so they weren't people that had to have it previously for rheumatoid arthritis or cancer or whatever. So then they looked at it and they went, oh my goodness, look at this. The odds of being on long-term were much higher in that high intensity group, 1/3 higher than they were in the others. So that's really damning from us, to be honest. And so we do have to look back and say to ourselves, why are we giving out these medications? And if we are giving them out, we're creating this problem. So we're trying to get the word out to as many people as possible. And lastly, we're giving out a lot of naloxone. So naloxone can save a life. It either comes in these nasal sprays, it comes in this atomizer, which is a lot harder to figure out how to do it, particularly if you're in an emergency. And it comes in this kind of like EpiPen thing, but this costs like, I don't know, $700, $800, ridiculous. So that basically, forget that. So this has 2 of them in there, and this has 1. So this is about $30, this is about $80. And we should be giving out as many of those as we can. And as I have said often, they should be everywhere. This is an automatic defibrillator. We keep those in airplanes. We keep them in any event that you go to. They're in a lot of churches. They're in places that people gather. And now certain people have been putting in EpiPens in these locations. This is from New Jersey school. And we think that you should put some Narcan in there, all right? So no matter where they are, I'd love it to be everywhere. Just go up there and pick it out. We've had 2 deaths in Starbucks in Connecticut, in bathrooms at Starbucks. So I'm particularly, since I've been to visit Starbucks a lot, I would actually wish there was one every time I went in there in case I needed to use it. So we believe that this should be all over the place. There's also great Samaritan overdose immunity laws in many states, and what that does is if we're using together and my friend here overdoses, I can call 911, and just because I have all this stuff around here, they're not going to arrest me or do anything. I have immunity for calling it and giving out Narcan. So we're trying to do that. We're also trying to data share. So Massachusetts and Baltimore had put together these great strategic plans, and they have shared data within sites. It's really impossible in states to share data. I've been trying to match people to the treatment facilities and then the ME's office, and it's impossible. And actually what we had to do was we had to get a law passed, and there was legislation package that actually did go through that said that we can data share between these state agencies, because if not, no one would give it to me. Even pre-hospital, I had to go through a lot of stuff, more than usual, not the IRB applications, but everything else, to give me their data so that I could then kind of map out where these patients were and see individual patients if in fact they were ever in treatment or not in treatment. So we've done that, and the last thing is the stigma, which is just what we started with, that words have power. So we need to keep talking about this. We put on a new and hosted a media roundtable at Yale, and we had everybody in there, and we talked about all these different things and lay people's views and how we'd wanted them. We know they need sound bites, so I gave them sound bites. And they came out with this great article about it the next day in the New Haven Register, and it says, "Doctors have better ways of talking about addicts." And I was like, oh my God, I just did this whole thing. It took us forever, and they write in the title. I was so upset. I called this person who was there. I go, like, what happened? And she said, I don't write the top part. I have nothing to do with the top part. It's my editors who do the top part. And I told them, and they still did it anyway. So, you know, you try, and then you have to go back and try again. So now we have to talk to the editors, but at least some people figured that out. So anyway, this is what language matters, and when we're talking about these, we'd like you to avoid these terms and use these instead. So it's a person with an addiction, it's a person with an opiate use disorder. It's not an addicted baby. When I told you about how addiction is, you have to do all these things. Your mind is preoccupied with it, you'll do it no matter what. Obviously a baby can't be addicted. There's absolutely no way a baby can be addicted. They can have an abstinence syndrome, but they can't have an addiction. Opiate abuse or opiate dependence, we'd like to talk more about opiate use disorder. It's hard even for me. It's a disease process, it's a drug addiction. We don't talk about clean and dirty needles. Do you ever talk about a diabetic that says they're dirty because their blood sugar is elevated? We don't scream and carry on when they come back with their diabetic ketoacidosis and they had a piece of birthday cake or whatever it was. We don't ever do that. So it's not clean and it's not dirty. It's a negative or a positive drug test. It's not substitution, and that's really important. It is not substituting one drug for another. This is a medication, whether it's buprenorphine or methadone. It is given a certain amount, it is given in prescribed doses, it's given under a doctor's supervision, and we expect a certain thing to happen from it. It can be, these medications can be used illicitly, but when they're used illicitly, like buprenorphine, they're used for people that are buying it on the street and there is diversion. It is being used because people are trying not to feel sick. They can't get more medication, they can't get into treatment, so they can buy some buprenorphine. So what? That's not a bad thing. If you're using the buprenorphine, you're not injecting, right? It's okay. Today's paper came out that San Francisco might have injection sites pretty soon to help with that, but we'll see. It's not relapse, it's return to use. It's not a failure, it's a treatment attempt. This is a chronic relapsing disease. You don't get rid of your diabetes, all right? You're not gonna get rid of this, and we're not being clean, we're being in remission or in recovery. So that's it, and our opportunities that we have gotten from the state and our abilities to bring in these vast amount of groups and people together from all walks have really let us embrace what is science-based, what is thought of and from all these organizations and supported by, which has a focus initially on high-risk individuals. We're maximizing it, and mostly we're changing these 3 T's about addiction: the way we think about it, the way we talk about it, and the way we treat people that have an addiction. So that's it. If you want to know more about that, this is also available on the Connecticut website, and that's it. Any questions?
My name is Shannon Monnet. I am the Lerner Chair of Public Health Promotion and also Associate Professor of Sociology, and I'm here to handle Q&A. I'd like to thank Dr. D'Onofrio for a really exciting, interesting presentation. And if you look at the program, actually, it says Q&A and my name under it, so I think that means I just get to ask all the questions because I have about 20 questions here. We have about 20 minutes for Q&A, so I think that there are microphones on the side, and just go ahead and raise your hand, and someone will bring you a microphone. And if nobody has a question, believe me, I can start.
It's just going to start.
Hi, thank you for coming here. That was a very informative talk. I'm curious, is there an economic dimension to people suffering from these issues? Is it mostly lower income rural folks, or does it affect the middle class at the same rates, or what are those distinctions?
A great question. So it really knows no discriminatory things. So it does affect everybody from every walks of life. And it's very different. We were talking about this earlier today. So there's a real big population of individuals in that Appalachian Valley who really have nothing to do with their lives. And a lot of hopelessness and other things. But outside of that particular area, and some's in Kentucky and the rest, and you can see in all the areas of the state, it really can affect anybody. And I see everybody from the most important people you can imagine who were given some prescription medications and then found they were having an issue with them and had an opiate use disorder, from people who I see that are homeless and on the streets. So it really is overall. It is primarily a white disease. If you look at the epidemiology, we didn't get this crisis over the cocaine in the 80s when I trained, which literally I was in a war zone. It was a black community. So I'm not afraid to say that. It is a white disease right now, and that's why you have the right and the left kind of coming together. But I'll take that no matter what. But it doesn't know any economic bounds.
Other questions?
Okay. Well, thank you very much for all the work that you're doing to save lives. I mean, this was an incredibly moving presentation, and a topic that I can tell you is on the minds of, I happen to be a mayor here in the country, and is on the minds of mayors all across the United States. I was at the U.S. Conference of Mayors not too long ago. Former President Bill Clinton came, spoke to us. You know, the very first issue when he sort of got to the issues that was on his minds was opioid addictions. I thought the one, you had so many different graphs and tables, but there was one that you had there about, and I can't remember all the details, but I'd love you to talk a little more about it, which was the states that opted out of the Medicaid expansion.
Yeah.
And I don't remember if that was in terms of the treatment of it, but I'm curious about those particular states and whether, because they've opted out of the expansion, opioid addiction is either more rampant or less treated. You know where I'm sort of going with that?
Well, they're not. It's not all. It's not as. It doesn't have anything to do with how many, what their problem state is. So when you think about the highest states, you were talking about Ohio. Ohio did take the expansion. We're talking about New Hampshire, which kind of took it late. maybe Massachusetts, high, one of the top 5, they did take it. So it really didn't have to do with the ACA whether or not they had the problem. But clearly how they're working towards that problem and spending the money allocated, that was from the Urban Institute, really depends on whether or not they had ACA, whether they were expansion state or not. They're spending more money, they're getting more people in treatment. Those places that didn't get it don't have treatment. So Maine, for example, is a huge problem, and they didn't take the ACA expansion, and there's no resources. So I did go there about a year ago and tried really hard to help them strategize, but in the end, I said the best thing you can do is take all the stories you just told me and go to your legislators and try to advocate for treatment, because I can't start something in your emergency department. I've got all the people geared up here, but they have to go someplace. I don't have any place for you. So, you need to go and lobby for that. So it really didn't, those top states, there's some Connecticut, but Kentucky is a large state, and remember, Kentucky had a great thing. That's a whole fabulous study there. They had Kentucky Care. Right? Kentucky Care really put a lot of people on the rolls of insurance, and people are getting care. And then another party came in as governor, and it went away. But people there didn't understand it when they were talking about ACA and this. It's the same thing. I don't have that. I have Kentucky Care. Well, guess what? You don't have anything now. So it didn't have anything to do with people getting the addiction, but it has a lot to do with treatment.
Other questions?
Hi. I'm talking strictly pills now, not heroin or anything.
Okay.
Would you say it's more of a physical or a mental dependency for the people who take them? And if they're not in pain, what purpose do these pills serve?
Well, similar to all the other opiates, when you take pills or heroin or whatever, that changed that reward system, and it sort of hijacked all of those neurotransmitters in that tire system. So it didn't matter what form you take, that same thing will happen. So it's a disease, and it will do the same thing as heroin. The problem with prescriptions are that it's so expensive, so people will then always move over unless you're very rich. But even people like, what's his name, the purple, no, Prince, even Prince, which was really sad. I was actually in Minnesota 1 week after he died, and people were very upset there because they have great treatment facilities there, and that he didn't feel that he could come out with a stigma of having an addiction, because he'd been so vocal about anyone that he worked with could not be using drugs. So he took them because he was dancing and he had all these musculoskeletal pains on using those very high heels, and he just it just got away with him, and so it was a big problem, and it didn't matter, and in the end he probably did use some fentanyl, but it's the same regardless of what opiate you take. It's the same reaction. It is a disease. It has nothing to do with willfulness, and which is my feeling about AA, or that if you need to say you give your life up to a higher power, if you're religious and then you fail, then you think there is nothing left for you in life. And I've heard these stories so many times from family members, and people have left notes or they've talked to them, and they've tried all this and they've given their lives up and they're trying to be good people, and they couldn't. Well, we know they can't because it's a brain disease. It's not a willfulness disease. And so we have to be really careful how we come out with that, because then people will relapse and think that they are worthless and that there's no hope for them, and then many of these overdoses may and well be suicides. We don't know that. We have so many bodies that are piling up in our ME offices, we can't even get to them. And so unless they leave a note, someone leaves a note, or it's obvious, they are taken off as a unintentional death. And many of them may not have been unintentional.
Over here.
Thank you for an excellent presentation. So let's move forward 2 or 3 years. So let's assume that the Connecticut model is successful and continues to be successful. What would prevent this from being a national model?
Well, first of all, the Connecticut model was just starting, all right? We have the plan, right? We have a little bit of money from SAMHSA. I think that I have 10 EDs that I'm working with. One is very geared up to work so far I've been to. The other one, pulling teeth. I don't know how I'm going to do it, to be honest. I told them I would be on call for them 24 hours a day, literally, to talk to anybody, but that's not feasible, obviously, for 10 EDs. So we're just starting it. There's nothing stopping it, and people are doing this all over the place. I mean, now the groundswell is coming out. People are finally realizing it. First line people from emergency departments are willing to participate in this. I think overall, I have had this one really bad experience, and that's because they're, how can I say this nicely? They are not community physicians. They're not involved in their community. That particular hospital is, what do you call it? Guns for hire is what I want to say, but there's a real term for that. They're brought in by other places. The hospital hired them. The director lives in Virginia, not in New London, which is a very, very high pocket in Connecticut. So he has no community relationships. He doesn't care, really. And again, doctors are paid sometimes by how much they see and what kinds of procedures, we call them RVUs. And this is not going to get you much of that. It's going to take some time. So we're working on how to make it as quick as possible. But we have to have people in their communities who want to work in their communities and make things work. And then I think we could spread it around, but it's going to take time. If you know, in all of medicine, when you know that something works, it's really been evidence-based, it takes 8 or 10 years to get into practice. So we're trying to escalate this as much as possible. But
one of the first questions you ask when you visit a medical practice is how much pain are you in?
Right.
And they go from 0 to 10. And so it seems to me that the medical profession is using pain management drugs quicker than they should be. And there's not enough on pain management and pain tolerance. So I guess, what do you do about that? Is the medical profession as much responsible for this as anybody?
Definitely. I mean, we did it. We did it with the pharmaceutical companies. We bought into it. We bought in that was the way it is. And it's easier to write a script than it is to talk to you or to offer some other treatments, which, by the way, are not supported by Medicare, for example. So you have an older person who has lots of pain. I have a mother who's going to turn 95 in 2 weeks, so I deal with this on a routine basis. She's always in pain. My sister, who's not in the medical profession, said, why don't you have a sugar pill? Because anything I do for her seems to work. So we've created all these different things. She puts Vaseline between her knees and it doesn't stick, and she thinks it's okay. So we have to come up with better ways of dealing with it. It takes longer. There's also one thing that you said reminded me to talk about, and that is we don't have the physician pipeline, we don't have the workforce. The amount of doctors we have that understand and know chronic pain is like less than 1% of what we need. And in my even group, I don't have any. We have a great person I work with, Will Becker, who's part of this, who's at the VA. And I'm calling him, I'm calling other people about patients, so we don't. Addiction medicine is a new specialty, right? We just became recognized by the American Board of Medical Specialties this year. It is under the American Board of Preventive Medicine, and is a specialty subspecialty, which means that if you have a board in any other specialty, emergency medicine, family medicine, OBGYN, whatever it is, internal medicine, psychiatry, you can sit for those boards right now, and there will be a 5-year grandfathering portion before you will need to do a 1-year fellowship in that. But there's only a few people in that. A tiny bit. Emergency medicine is less, again, than a few percentage of that. There are a lot of psychiatrists, family medicine, and then next is internists. So we have to get people interested in this, and we have to think of it as a consult. So all primary care doctors take care of hypertension or diabetes, but they send somebody when it's out of control to a endocrinologist or a cardiologist for a consult because I've done everything I can't seem, and you do a consult and then you bring the patient back. So we have to think of these creative ways of how we can consult. We have to think of, this could be done actually remotely through video conferencing, but you know, all the barriers associated with giving out an opiate across state borders, right? So it is crazy. We're now allowing providers, advanced practice providers, APRNs, to have X waivers. They have to have 3 days of training, but we are allowing that. So it's possible in rural areas that we can bring this out better with having other providers. But really the doctor just needs to talk to the patient. This is one thing where we don't have to do much of a physical exam. All right, we might in some cases because they might have sequelae of liver failure, et cetera. But in many cases, we can do that with advanced practice provider. We can talk to the patient and then we can help prescribe and not be there right there at that moment. So we need to do that too. And in rural areas, this is a big deal. In Vermont, we're up there now trying to do this little pilot. There's no place to send anybody to. I have, again, these doctors working in the emergency department who are not boarded emergency physicians. They're great people, but again, they're coming in under this, what do you call that? They're hiring them, you know, it's a different, locum tenens, yes, thank you. They're bringing these locum tenens and, you know, they're different people today, they're different people next week. So how do I go about teaching them and talking about a practice protocol? I think that I might be able to partner with one of the insurance companies who's reached out to me and said they would pay for all payers to kind of put some videos together, to put some high quality educational things out there that we could put on their hospital intranets, that I could ask them to look at it for it has to be 5 minutes, they're not gonna look at it. So there are all these things.
So we have time for one more. Oh, roll.
I can stay after.
Thank you. So we've talked a couple of times about problems with the physician pipeline and not having adequate numbers of certain types of physicians, or problems with shortage of physicians and having locum tenens people come in. If we were to focus upstream a bit from that,
Yeah.
what interventions do you have or thoughts do you have for ways we can change medical education, either at the graduate medical education level with your residents at Yale, or for medical students like here across the street? What are your thoughts for that?
So great, we are doing that. Many medical schools are doing that. We just went over our entire curriculum, a group of us, and we looked at every single piece from the basic sciences on to the clinical areas, and in every area we implanted something that we thought was important. And so we're requiring that, and everybody's really been on board about that as long as we gave them the content and we told them what we wanted to talk about. So I think that's true everywhere. And more medical students that I'm talking to, we're about to go into our now interviews, and I'm talking to people, and people seem to be well aware of this crisis and being able to do that. So I think we're on that wavelength. We have to do more with prevention. That's not my area, but we need to do it. We need to get more grants out. Yes, we need them for treatment, and we need to do that right away, to treat and not arrest and everything, but we need to figure out how to get people to not start in the beginning, and most of these kids are starting at 12. You know, they're using marijuana. We didn't even talk about other medications, but marijuana is out of control. Cocaine is now out of control. 3 times more people are using cocaine this year than they did last year from the household survey. Marijuana is a nightmare, all right? Is a nightmare. And people, when you talk about, and you listen to patients, and you listen to mothers talk about their deceased children, they started with marijuana at 11 and 12, and then they progressed up. So we somehow got to figure out how to prevent that. I'm the mother of triplets who made it to 27, almost 28. So, but I'm happy that they're that far along now, because it's really hard. You go somewhere and you take one of these fake pills, or you take what you think is a little bit of cocaine, and you could die. So it's really to get out there. And I have presented this at the law school. We're doing a whole semester course on law. I should probably not say this, but. So we're doing this whole class on law and opiates, and a law student came up and said to me, "You mean that stuff that we use at parties to check on what these drugs are doesn't work for this?" And I'm like, really? She really asking me that? So I said, no, it's not going to work with that. I can't even tell you what is fentanyl. I don't have the capacity of doing that. I don't have a stick. I do, but it's only for experimental use for studies. It's not, and it's forensic use only. So I said, no, you don't, and please don't even try that. If you don't know what you're taking, why are you taking it? That's someone highly educated. So
on that note, please help me thank Dr. D'Onofrio. Many thanks to the Lourie family for their funding and for
Yes, thank you.
Community Foundation. We'll be having a reception if you'd like to join us there in the Commons, and there are folks at the door who can direct you if you don't know where that is. Thank you all for coming.
thank you.